Hello everyone. Our theory is cognitive theory, and we'll be identifying from principles to practice methods. I'm Shireen Farsi, and I will be identifying and defining principles of the theory. Alan Donald will provide examples of practice settings. Ashley Fagnani will be discussing strengths of the theory, including its role with diverse client systems. And lastly, Amber Gagnon will be identifying limitations of the theory, including its role with diverse client systems. Identifying and defining cognitive theory. So cognitive theory stems from the traditional psychological concepts of thinking, combining behavior theory and cognitive theory. This was developed in the 1950s during the cognitive revolution. So basically, the concept of cognitive theory states that it includes behavioral theory, which discusses how our actions are affected by what happens before behavior and the consequences that follows. So cognitive theory builds on behavioral theory in that by suggesting that thoughts, not just consequences, influence behavior. So therefore, if behavior theorists believe that by educating clients on how the consequences of their behavior can deter future action, then cognitive theory is similar in that by educating clients on how their thought process affects their emotions and behaviors, then clients will change the decisions they make. And I'll go into that a little bit further. So there are main theorists, which are listed: Alan Pavio, Robert Gagni, Howard Gardner, and Benjamin Bloom. So Alan Pavio, basically, his theory stated that people process information in two ways: processing images or processing language. And then Robert Gagni had 5 categories of learning: verbal information, intellectual skills, cognitive strategies, motor skills, and attitudes. Howard Gardner developed a theory to understand and define the 11 intelligence levels, which include gain attention, inform learners of objectives, stimulate recall of prior learning, present stimulus material, provide learner guidance, elicit performance, provide feedback, assess performance, enhance retention and transfer. Benjamin Bloom classified learning into 3 domains: cognitive, affective, and psychomotor. And the steps included creating, evaluating, analyzing, applying, understanding, and remembering. So basically, these theorists are helping behaviorists to understand the levels of thinking and processing that an individual has, as we are all individuals. So as stated previously, cognitive theory and behavior theory are combined. Cognitive theory concepts include how we think and understand things, how we comprehend and see the world around us, and conscious thinking. One form of cognitive theory or intervention is cognitive behavioral theory. So that combines cognitive theory and behavior theory, known as CBT. So CBT is a short-term goal-oriented psychotherapy which focuses on distorted thinking and core beliefs, which influence an individual's thoughts, behaviors, and emotions. The thought process on this approach is if an individual changes their thoughts, then this can reduce symptoms associated with a mental health disorder. CBT can be effective to a wide variety of clients, from those suffering from depression, anxiety, to those with drug or alcohol abuse. The advantages of CBT are that it is short-term, being 5 to 10 months for most diagnoses, with 1 session per week lasting 50 minutes. CBT focuses on the client's distortions and core beliefs. The theory states that if one identifies their core beliefs and distortions with the practice of mindfulness, symptoms of anxiety and depression can be reduced in a short time. Cognitive distortions are a negative thought process of thinking, which influences the client's emotions and behavior. In the study conducted by Renick, distorted thinking influenced the client's ability for self-enhanced humor and a direct relationship between those who experience depression and negative outlook on life. Cognitive distortions were developed by Beck, Rush, Shaw, and Emery in 1979, identifying a list of 10 distortions which included mind reading, catastrophizing, all or nothing thinking, emotional reasoning, labeling, mental filtering, overgeneralization, personalization, should statements, and minimizing or disqualifying the positive. Cognitive errors may occur with differing frequency across social and achievement domains, particularly depending on the content of an individual's core beliefs, which typically fall into two categories: feeling unlovable or dependency, or feeling helplessness, autonomy, or achievement. For example, an individual who has social anxiety will be socially withdrawn, having negative core beliefs affecting self-esteem, such as I am unlovable, I am not important, I am helpless. The Young Schema Questionnaire YSQ was developed to identify core beliefs, an assessment of maladaptive beliefs, emotional deprivation, abandonment, mistrust and abuse, and social alienation, defectiveness, incompetence, dependency, vulnerability to harm, enmeshment, subjugation of needs, self-sacrifice, emotional inhibition, unrelenting standards, entitlement, and insufficient self-control. Research indicated in the article by Millings suggests that predictors of anxiety clients are those who have abandonment issues, vulnerability to harm, failure, self-sacrificing, and emotional issues. On the other spectrum, those suffering from abandonment and insufficient self-control had a higher likelihood of depression. Basically, cognitive theory discusses the way we think and how that influences our decisions and behaviors. And one intervention which combines cognitive theory and behavior theory is CBT, cognitive behavioral theory, which combines both. Therefore, in summary, stating that if one is assisted in identifying their distorted thinking, like, I'm not good enough, I'll never accomplish anything, those are some distortions. And then getting the client to understand how this affects their thought process, which ultimately affects their behavior. So mindfulness is huge in CBT. And through this method, clients can kind of change their thought process, if not completely.
Hello, everyone. This is Alan Donald. When we're looking at uses for cognitive theory-based interventions, we found that there were several common practice settings, which included community practice setting like community mental health centers, mental health clinics, substance use clinics, outpatient clinics, inpatient settings, and also other settings like school-based services, jail-based interventions, and also even in the workplace. Applications were diverse and universally showed promise, though some had a larger effect size than others and showed better outcomes. For substance use disorder, the effect size was smaller when compared with other interventions like motivational interviewing, contingency management, relapse prevention, and this was specifically with certain substances, including people coping with an opiate or an alcohol use disorder. Psychotic disorders, there was a medium effect size for both the positive and negative symptoms. For mood disorders, including depression, Tolan found it was superior to psychodynamic interventions, and other studies showed that it was at least equally effective. With anxiety disorders, perhaps there was the best results, the best outcomes. Hoffman and Smits found that a cognitive-based approach should be the first-line approach in dealing with anxiety disorders. And there were lots and lots of other uses, including body dysmorphia, insomnia, eating disorders, personality disorders, anger management, chronic pain, even smoking cessation. As far as diverse client systems, children and adolescents showed the most promise. They showed significantly better outcomes when compared to no treatment or other treatment and medication for anxiety, and more mixed for other disorders. For the elderly, CBT specifically showed promise when compared with reminiscence, which is perhaps the most well-known and common intervention with elderly populations. As far as minority populations, the researchers were pretty much unanimous that there was limited research and there needed to be more research. And they also agreed that every approach using cognitive-based theory should involve cultural competence and adaptations specific to cultures. So one study looking at comparing Latino and European American youth with anxiety disorders found that both of them responded positively to a cognitive-based intervention. Another study looking at the effectiveness of cognitive behavioral therapy for anxiety disorders among gay, lesbian, and bisexual clients found that it was effective. And then another study looked at case studies of two immigrants, one from China, one from Central America, and found that cognitive behavioral therapy was effective in those cases as well.
The ease of cognitive theory's application extends itself to other social work theories as well. Cognitive theory is easily combined with other theories, the most popular being behavioral theory, which has led to the widely adopted cognitive behavioral therapy, or as it is most often referred to as CBT. Because cognitive theory focuses on what a person is thinking, as that directly affects their behavior, this theory delves deeper under the surface of a client concern, enacting changes that influence how the person is as an individual and how they interpret and react to situations. The symptomatic change that comes from implementing cognitive theory into practice is a great strength, as it is not just addressing the concern at hand, but can impact the client in other aspects of their life as well.
So we've had a chance to explore some of the strengths and application practices for cognitive theory, but I think it's time now to kind of review some of those limitations. While cognitive theory has many strengths and applications in practice, it also has limitations that need to be understood and reviewed. Cognitive theory is extremely useful in micro practice, especially on a one-on-one setting, as it helps the practitioner understand how and why a person may function the way that they do. This, however, does not exactly translate well to larger systems. Cognitive theory by itself does not account for systemic influences that come from larger systems, such as the family unit, communities, or even cultures at large. Additionally, in our field of social work, it is critically important to consider a person's environment. We want to know how a person's environment may impact their functioning, the choices that they make, the barriers that they face, and countless other variables. As a social worker, we know that culture and inherent beliefs tied to culture greatly impact our clients and their life experiences. Cognitive theory, however, does not examine this influence. This lack of consideration for culture can make it difficult for a social worker with knowledge or practice skills that are grounded only in cognitive theory to deliver culturally sensitive services. Cognitive theory is solely focused on the individual person, their conditioning, their reinforcers, and their punishers. But cognitive theory does not take into account a person's environment or culture, and for that reason, when used alone, it does have serious limitations. In modern-day social work practice, cognitive theory is often combined with a complementary theory to offer a more comprehensive approach. Frequently, cognitive theory is melded with behavioral theory to create cognitive behavioral theory. Another popular combination is social cognitive theory, which helps bridge that knowledge gap in considering how people interact with their environment and other factors like culture and the influence of larger groups like communities. Cognitive theory can offer a strong base of knowledge for understanding thinking patterns and conditioning. However, to deliver the most well-rounded and culturally sensitive practice in our field, cognitive theory is best used as one tool among others. Cognitive theory can be complemented by these other theories, which help to make up for some of its limitations.